And I'm dressed like this because after the grand rounds, I'm going to fly out to a place called Slovenia, in Eastern Europe. And I don't know why I chose this. I have to give this grand round on hyponatremia and then talk on vascular access. So, but anyway, maybe being under pressure will bring out the best in me. So this is a topic that I think fellows, residents, they always worry about. There's a patient with hyponatremia, what should I do? And you have this feeling, if you don't do, you are damned, and if you do, you may be damned, in that kind of situation. So I'm going to go through this topic, first focus a little bit on the diagnosis, and then go over the guidelines. And guidelines have come from the United States and from Europe. So it's interesting to see how people across the pond think. So it's always good to start with a case. And this is a case that actually happened last month. And Dr. Buffington was a consultant. So there was a 44-year-old man who was admitted to Willis-Knighton North with, actually he fell and he had a subarachnoid hemorrhage and a subdural hemorrhage. And he had a history of alcohol, excessive alcohol intake, and perhaps that contributed, or he may have had a seizure. His sodium, when he was on the 26th, on the 24th, we have a sodium of 140. He was discharged on the 26th. And after going home, his wife says that a day or two later, he just didn't see himself. He was getting confused. And then it became an emergency. So on the 1st of March, an ambulance came and they intubated him. He had acute respiratory arrest, and he was brought here to our MICU. And they repeated the CT head, and he had hematomas, and he had also a left parietal infarct. And his sodium was 150. Serum osmolality was 249. The urine osmolality was 457. The urine sodium was 32. Urine potassium 12. And the urine to serum electrolyte ratio was 0.38. And you're wondering, what the heck is that? His BUN was 11. His creatinine was 0.68. Okay. So now the question is, was that acute respiratory arrest from the underlying subdural hematomas, or was it from the hyponatremia? And this is the dilemma we always have when we deal with these patients. So let me say a few words about clinical practice guidelines. Clinicians regularly face situations with two or more actions. Okay? And each action will have some advantages, some disadvantages, differences in effectiveness, adverse effects, costs. So this is the situation in hyponatremia. And to make these choices, how do we make these decisions? One is we can go to these practice guidelines. We can ask a senior colleague, or whom we think is go on the phone, call an expert, or from our own personal experience, or saying, oh, that doctor did that, from someone else's that you watched, or when you didn't. So that's how we make these choices. Now, to make the guidelines trustworthy, we expect groups of people with relevant skills, perspective, and knowledge. They get together, they use the best available evidence, and they systematically develop these guidelines. So that's the expectation. So you'll notice in guidelines, and this may be something, old hat to you, but you will see whenever they give you a guideline, they will say 1C or 2A. So what they mean by 1 and 2, 1 is a strong recommendation. Okay, so they will say, we recommend. Or it may be a weak recommendation. They'll say, we suggest. All right? And then they'll give you the strength or the quality of evidence. So if there's a randomized controlled trial or a big retrospective study, okay, or a prospective cohort trial, you may get evidence that is high or moderate. But if there are a few case reports, some reviews, some expert opinions, it may be low evidence. But some things are self-evident. So you may have a recommendation that may not have quality of evidence. Like when it rains, you get wet. You don't need a paper to explain that. So that's a strong recommendation, right? So having said that, the implications of these guidelines are for three stakeholders. The stakeholders are patients, the clinicians, and the policymakers. So if you have a strong recommendation, we recommend, it means that most people in this situation would want the recommended course of action, and only a small proportion would not. And for weak, we would say most people in this situation would want the recommended course of action, but many would not. Okay? So that's the difference. Now for a clinician, if you have a strong recommendation, I think that's the correct line of treatment. But when if it's a suggestion, you have to individualize. You have to discuss it with the patient's family, because the recommendation is not strong. So it may be unique for each situation. And the same thing goes for policy. When it's a recommendation, you can make a policy. But when it's a suggestion, you have to have a debate, a discussion, to decide what policy you're going to use. So this is sort of behind these guidelines. So now let's go to our main topic, and that's hyponatremia. Everyone agrees that when the sodium, the range is usually about 136 to say 145, that if it drops below 136, 135 and lower, that is hyponatremia, and that in itself should not worry you, okay? So it's not a disease, number one. Hyponatremia is not a disease. It's an expression of certain diseases, like heart failure. Everyone says, if you have severe hyponatremia, heart failure, it tells you that this heart failure is really bad. And so you could die from the heart failure, but you could also potentially get hurt from the hyponatremia. So it can lead to a wide spectrum of clinical symptoms from subtle to severe, that's the hyponatremia, or even life-threatening, and is associated with increased mortality, morbidity, and length of hospital stay. And it's one of the most common electrolyte disorders. 15 to 20% of hospital emergency admissions, and up to 30% in hospitalized patients. Okay? So basically when you see hyponatremia, there's a problem with, not with salt, but regulation of water. The patient is not able to get rid of water. Okay? So it's a disturbance in water metabolism. So why are we concerned about hyponatremia? This is an old diagram from an old paper. And if you look at the first picture, here's the normal brain with normal osmolality. And when you immediate effect of hyponatremic state, you can't get rid of water, your brain cells are going to swell up. And since the brain is in a cranial vault, it has no room to expand, you're going to get sick. But the brain is very intelligent, and it will immediately start, all cells in fact, will start getting rid of osmoles. Potassium, sodium, chloride will be extruded out of the cells. And as it does that, water will leave the cell. So the cells will start shrinking. And then long term, so this happens usually very quickly, but by 48 hours, okay, the brain is able to get rid of organic osmolytes, okay, and even adjust further. And that's where you see the distinction between acute and chronic. Okay, the physiology is much better for the brain at 48 hours. But it's still not returned to this state. It is still swollen. And that's where we come in. So we start treating this hypoosmolar state. And if we treat it correctly, we will return the brain to this state. But if we treat too quickly, we correct it too rapidly, then we may get the brain that had already adjusted, we may shrink it. And we may cause another problem called osmotic demyelination syndrome. So that's the situation we are in. If we don't do anything, we'll have problems, okay? And then if we do, there's a potential for problems, okay? So that's the dilemma for the clinician. So now this is, looks like a bunch of numbers and lines, but let me just go over it because this gives you the physiology. On this line, you can see the osmolality, okay? And normal osmolality, I've written down, is 285 to 295. We're trying to aim for 290, okay? Now, if you can't get rid of water and the osmolality keeps dropping, when you hit 280, okay, notice your arginine vasopressin is almost zero. And that's around the point where your urine osmolality will be 100 or less. So if your urine osmolality is less than 100, you can say, well, the AVP or antidiuretic hormone is shut off. You don't need to get a lab value just from that osmolality, all right? Now, notice you are thirsty around this level. And notice that as you lower the serum osmolality, you start getting rid of water. Your volume, this is the volume, increases. You're getting rid of free water if everything is normal, okay? On the other hand, if you don't drink enough water, the osmolality starts going up, you decrease the urine volume, and the urine osmolality goes up, okay? So that's your normal physiology, and that's happening while you're watching and listening to me. Your body is doing all this, okay? Now, the abnormal part comes where there's no stimulus for the release, the normal release, okay? In fact, you have hypoosmolality, you have hyponatremia, here we said 290, you're dropping this way, and arginine vasopressin is not shut off. You want it to be shut off, right? That's what it normally would do, but it's not shut off. And here is an experiment in rats, okay, where they made rats hyponatremic, but they also made them hypovolemic. And when they became hypovolemic, the arginine vasopressin levels go up. And that's the condition where, for example, you have heart failure, which is much simpler to explain, right? You have a decreased cardiac output, and the baroreceptors in the carotid arch, the carotid sinus, they sense that. And they override the signals to shut off. The low osmolality is trying to shut off ADH, but the volume is sensed as low volume because the body is more interested in volume than osmolality. And you have a high ADH, and you maintain the hyponatremia. So a few words about vasopressin and hyponatremia. Non-osmotic secretion of vasopressin is seen in 97% of patients with hyponatremia. Okay. Hypotonicity normally suppresses vasopressin. Therefore, reasons for non-osmotic release of vasopressin should be considered. So when you see patients with severe hypo, you have to think hypovolemia or low effective arterial volume. Okay, that's simple, right? Volume depletion, vomiting, diarrhea, you will get hyponatremia. Thiazides is a very tricky one because thiazides can cause normovolemia. You're not volume depleted with thiazides. And you have a problem, they say here, with impaired urea-mediated water excretion. So when you're on thiazides, you're not excreting the water. And you have hyponatremia that mimics SIADH. Looks just like SIADH. And the urine sodium is high. Then underlying diseases or drugs may cause release of vasopressin. And vasopressin can be produced from small cell lung cancer and olfactory neuroblastomas. And when you have a low ACTH, you cannot suppress vasopressin. So when you have a low cortisol, you can have hyponatremia. So I told you that urine osmolality, when you measure it, if the urine osmolality is less than 100, you can be sure that AVP, vasopressin is shut off. Now, vasopressin is difficult, they say, to measure because it's very unstable. It binds to platelets. And so now they have another molecule called Copeptin, which is very stable. And the Copeptin is when you break down vasopressin, you produce Copeptin. Okay? So it's a surrogate marker for vasopressin. It's much more stable. And in this study, notice the word SIAD. They're not calling it SIADH. Syndrome of inappropriate diuresis. Okay? Inappropriate diuresis. And I'll tell you why when we finish this. If you look at the gray zone and this dotted line, that's the normal relationship between serum osmolality and Copeptin levels. Okay? So the Copeptin, now remember, is representing vasopressin. Okay? So notice that when you hit like 280, you have suppressed Copeptin, very low levels of Copeptin. But notice that there is this type B, SIADH, type B, where it mimics the normal, but suppression occurs at much lower osmolality, at 260. Okay. Whereas in this type A and then type C, it just doesn't change. It doesn't matter what your osmolality is. And in fact, in type E, it goes the other way. Okay. It is high, it goes high when you are hypoosmolar. And then you have type D, where ADH level is not elevated. And this is the type D that gives this name because it perhaps is related to hyperactivity of aquaporin 1 or hyperactivity of the receptor. Okay, so it's at the receptor level, similar to, say, Liddle syndrome, where you have high ENaC function. Here you have high activity of aquaporin, and that results actually in suppression of the Copeptin levels. And that's why this is called syndrome of inappropriate diuresis, because in D, ADH levels are not high. And in this paper, notice the highest levels of ADH you find, I think, in hypovolemic hyponatremia, and then here is SIADH, and here is psychogenic polydipsia, where the patient is drinking large volumes of water, and you have suppressed Copeptin levels. So now, when you look at hyponatremia, when we started, we said, okay, hyponatremia is a low serum sodium. Okay? So we can classify hyponatremia in many different ways. So the first way of classifying would be to say the degree. Okay? Severe versus not severe. So moderate versus severe. Now notice the Europeans like to call it profound. Okay? The Americans like to call it severe. So I don't know why they have chosen this, but that's how they felt that the US panel felt that severe, they mixed up severe with symptoms. Okay? Whereas when they said we are using the word profound, we only mean the sodium without the symptoms. So anyway, then you can divide it into acute versus chronic, and I said in 48 hours, the hyponatremia is now chronic, and your approach to it may be a little different. And then finally, symptomatic versus asymptomatic, and that's very important, because when the patient has symptoms, your approach is going to be totally different. You have to treat the patient. You can't just sit down and say, oh, you have to act. Okay? So what are the symptoms? The moderate symptoms are nausea without vomiting, confusion, and headache. Severe or profound hyponatremia, the symptoms, usually sodium of less than 125, vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, and coma. So I think the patient who was admitted to our hospital was in this severe. Sodium was 150, and the patient was actually in cardiorespiratory arrest. Okay? So that's one way of classifying. Then you have a second way of classifying, and it's important to know this because when we follow an algorithm, there's a hypotonic, there's isotonic, and there's hypertonic hyponatremia. So to divide it this way, you have to get the sodium and you have to check the osmolality. All right? So The most common type of isotonic or hypotonic hyponatremia is hypoglycemia. Very common, right? Glucose is 500, the sodium is low. Per 100 of glucose, the sodium will drop by about 1.8 to 2. And you don't have to do anything because the brain is not swollen because glucose is an effective osmotic. All you have to do is treat the hypoglycemia and the sodium will correct. So if you see hyponatremia in this setting, nothing to worry about, correct the glucose. Then you have the presence of ineffective osmoles. So in this setting, if you were to get an osmolality, urea, alcohols, ethylene, the osmolality is high. But these osmoles move freely between cells and the extracellular fluid. So they don't cause hyponatremia. Okay? And then finally you have this isotonic hyponatremia, which is the laboratory artifact. So if you have high cholesterol, high triglycerides, high protein level, someone gives IVIG, okay? That compartment becomes big, and so there's an artificial decrease in the sodium. But if you do the osmolality, it will be isoosmolar. Okay? So you have to get the sodium. This thing fell out of its nest. All right. So you have to get the sodium, and then immediately after that, you need to get the osmolality. And if the patient is hypoosmolar, then you move down that algorithm. All right. Then the third way is the United States way of doing in our original teaching. As soon as we saw a patient with hyponatremia, we were told, go and examine the patient. Does the patient have hypovolemia? That means low blood pressure, low postural hypotension, and so on. Hypovolemia, edema, shortness of breath, okay, ascites, or euvolemia. Okay, and classify the hyponatremia based on the physical examination. So this is how I approach it. Serum osmolality, you've got hyponatremia, serum osmolality low, you come down there. You do your physical exam, and then you have heart failure, cirrhosis, and nephrosis when patients have edema. The problem with this approach is that it's difficult to separate these two in real life. The normal volume versus low volume is difficult, okay, to separate. I'm going to come back to that topic later. Okay. So now, when you see a patient with hyponatremia, profound or severe hyponatremia, you should have a differential in your head. You know, which are the causes? So the most common cause is SIADH. Okay? In this large series of patients, 136%, so 1/3 SIADH. Next is diuretic use. So it could be a loop diuretic, like Lasix, which will cause real volume depletion, or it could be a thiazide, where you don't have volume depletion and mimics SIADH. Then you have hypovolemia, hypervolemia, primary polydipsia, and then cortisol deficiency. Just to refresh your memory, the criteria for SIADH are having a low serum osmolality, an osmolality in the urine more than 100, because when you have an osmolality more than 100, it means that you have ADH on board. Okay? Euvolemia, a urine sodium cutoff of greater than 30. Okay? Absence of adrenal, thyroid, pituitary, renal insufficiency. No recent use of diuretics. So there are lots of exclusionary criteria. You have to rule them. It's not this, so it must be SIAD. And then there are some supplemental criteria. Uric acid is low, and fractional excretion of uric acid is high. This is especially useful when you're trying to separate SIADH from, say, a thiazide. Okay? Because in SIADH, serum uric acid is low. Uric acid excretion is high. And then serum urea level is low, fractional excretion of urea is high. Okay? And then fractional excretion of sodium is 0.5%. And failure to correct hyponatremia after an effusion of normal saline. So these are supplemental criteria. Now, there is another entity called cerebral salt wasting. It's very rare, but it keeps on coming up. Okay? The cerebral salt wasting, if you want to separate it from SIADH, the main thing is volume, urine volume is high, and the patients get orthostatic hypotension, and the central venous pressure is low. So in these patients, if they are not corrected, they are going to get volume depleted. So that's different from SIADH. In SIADH, you have euvolemia. Okay. So now let's go back to the guidelines. So there are two sets of guidelines. The first set of guidelines came from a panel of experts, and it was published in the American Journal of Medicine in 2013. And these are all stars in the US, experts in hyponatremia. But these guidelines were funded by Otsuka Pharmaceuticals, the maker of tolvaptan. So you have to take that into account when they were given an unrestricted grant to write these guidelines. The Europeans, on the other hand, got three societies together. They got the Endocrine Society, the Nephrology Society, and the Critical Care. And they got them all together, and then they sat down and came up with these guidelines. Okay, so those are the differences, whereas this was not from a society, this was a group of experts. So I mentioned to you in the US guidelines, there's a great emphasis on the physical exam, right? Doing this physical exam. Now, the problem, as I told you, with the physical exam is that it's very difficult to separate hypovolemic hyponatremia from euvolemic hyponatremia. Okay? And hypovolemic and difficult to separate. Okay? And the clinicians often misclassify hyponatremia when using algorithms that start with the clinical assessment of volume status. This is the Europeans felt that this was a problem, and they actually, there was a paper to test this hypothesis, the performance of physicians in training, that is our house staff, okay, using an algorithm. So the house staff were given an algorithm, and they compared their assessment and their therapy to senior physicians. And these were people who were critical care doctors. And who was the standard? They're sitting in this corner. The standard was the endocrinologist. Okay? So this is that paper where they gave the algorithm to the residents. They told the experts, you manage the hyponatremia. And then they got endocrinologists, okay, as the gold standard. And this is what they found. The overall diagnostic agreement between algorithm and reference standard was 71%. Okay? That means residents versus the endocrinologists who were the reference standard. Whereas the agreement for senior physician and reference standard was 32%. They didn't do well. And regarding the therapeutic consequences, the residents with the algorithm, 86% versus the senior physician, 48%. So the residents, just using the algorithm, perform better. Okay. So this is the algorithm that they used. And it started with what I have just told you, serum sodium less than 130, measuring the serum osmolality. Okay. Then you have three buckets here. Hypotonic hyponatremia is what we are concerned about. Then you do the urine osmolality. See, some of these are decisions, some of these are actions. So urine osmolality, if the urine osmolality is less than 100, you are dealing with this primary polydipsia, low solute intake, and potomania, that is beer drinkers' potomania. If the osmolality is greater than 100, then you check the urine sodium. If the urine sodium is less than 30 and you have hypovolemia, okay, then you have all these disorders. Okay? Pancreatitis, third spacing, GI losses, vomiting, and so on. If you had hypervolemia, then you are thinking about heart failure, liver cirrhosis, so edema states. Okay. On the other side, and they made a mistake. Notice here they put hypovolemia and hypovolemia. It's really hypervolemia. I had to correct it. Okay. So if the urine sodium is greater than 30, okay, then you have hypovolemia or hypervolemia. In the hypovolemia, you have SIADH. Notice here, hypothyroidism, SIADH, and so on. It's interesting that hypothyroidism very rarely causes hyponatremia. Almost, it rarely causes hyponatremia. So now, here is where there were some pitfalls. And this was, I think, diuretic-induced hyponatremia, especially with the thiazide diuretic. Often they would call it SIADH. Okay? So there was a mix-up there. And the other place where this primary polydipsia, they used the cutoff of less than 100, right? Less than 100. If they had used, and they have put millimoles, it's milliosmoles actually, so it's printing. If it's less than 100, they missed, I think, 4 out of the 5 patients. And had they used the cutoff of less than 200, they would have got all the patients. Okay, so there is for primary polydipsia, if they use a cutoff of less than 200, they got most of the patients. And the other one was, if you want to separate hyponatremia from diuretic use, especially thiazides, SIADH, then the fractional excretion of uric acid helps you discriminate and moves the sensitivity and specificity upwards. So now the European algorithm is much more simpler. It starts with hyponatremia, then you have hypotonic, you do the osmolality. Now, if you have symptoms, you immediately start treatment. Okay? You have symptoms, you go into treatment, you don't have to waste your time with this. If your patient is not symptomatic, then you can go here, urine osmolality, look at it less and more, do the urine sodium. So all these tests, and then you have, this is much cleaner, okay, less than 30, you go here, more than 30 here. And here the separation is, consider if the patient is on diuretics or not, okay. So we have already gone through that, but there is one more, a trial of volume expansion with normal saline. We are always scared to give normal saline in a patient with hyponatremia. We are afraid that it will make the hyponatremia worse, but that is not always so. And there is a paper here where they took 17 patients with known SIADH and they gave them 2 liters of IV saline over 24 hours. In 11 of 17 patients, the sodium actually went up. Okay, so these are those 11 patients, the sodium went up. But in 6 patients, the sodium actually went down. And the cutoff was a urine osmolality of 500. So if your urine osmolality is more than 500, if you give saline, your saline may be desalinated. There's a condition called desalination, and you can make the hyponatremia worse. But if your urine osmolality is 300, 200, giving saline may actually correct the hyponatremia. So now I have finished with discussing the different types and so on. Now we are coming to the action part. What do I do? Okay. So the first is, I'll just give you a list of causes of acute hyponatremia. Post-operative period, patients are in pain, so they release, a lot of release of ADH is occurring. If someone is giving D5W as the IV solution, patients can get acute hyponatremia, especially described in women after sometimes small surgeries. Exercise, when people overdrink, like the Boston Marathon. Self-induced, like that radio, there was a talk show where there was a challenge and one woman died. She just kept drinking tons of water and she got acute hyponatremia. Ecstasy, a bunch of drugs, and irrigants used during transurethral or hysteroscopic procedures. So if you have acute hyponatremia and you're going to have symptoms, okay, because it's happening so fast, the brain is going to swell quickly, okay? So you have to act. And the nice thing today is you don't have to calculate. No need of calculations. You just give boluses of 3% saline. Okay? And that if you look at the US guidelines and the European guidelines, just a little difference in volume. Basically, it's 3%, and you're trying to bring the sodium up. Now, how much you bring it up is, we will discuss. So, for moderate symptoms, the Americans said you can give a continuous infusion, while they said give a bolus. So, basically, you want to, I would just give boluses until I'm satisfied and raise the sodium. Now, chronic hyponatremia, on the other hand, I've already discussed the degree, okay? So the mainstay of chronic hyponatremia is fluid restriction, okay? So does it always work? So here's a paper that looked at fluid restriction. Fluid restriction to 1,000 ml per day was effective in up to 60% of patients. So the majority of patients will respond if you restrict fluids to 1,000 ml per day. However, if the urine osmolality is very high and the urine sodium is very high, okay? Now notice here the urine osmolality is less than 300, urine sodium is less than 50. You're more likely to respond to 1,000. But if your osmolality is more than 500, that's the group that actually got the hyponatremia worsened when you gave normal saline. 1,000 may not do it. You may have to restrict to 500. And 500 is very difficult for patients to restrict fluid to. Okay? So sometimes, majority of the time, it will work. Sometimes it doesn't work. Now, what about the second line treatment? Demyclocycline, I think there's only one paper out there that shows a little bit of change of sodium, but a lot of acute renal failure. You can have renal toxicity. So the Europeans said no. They don't even recommend demyclocycline and lithium. They do not recommend. Okay? So the second line of therapy for the US is Vaptans. The Europeans, on the other hand, do not recommend or recommend against Vaptans. Okay? So there is, the FDA says the Vaptans cause liver dysfunction. Okay? And they recommend giving it only for 1 month. But we all know that there are patients who will need Vaptans. Okay? And I will show you through this case that some patients will need Vaptans because the restricting fluid to 500 cc's is very difficult in those patients. They will need. So, so there are situations where Vaptans may be necessary. The second line therapy is urea or loop diuretics plus oral sodium chloride. And they gave urea but not sodium chloride in the US guidelines. Okay? Then for hypovolemic hyponatremia, it's quite straightforward. You want to give normal saline, okay? Or maybe Ringer's lactate solution. And in hypovolemic hyponatremia, again, fluid restriction is the mainstay. But the US recommended Vaptans, and they recommended against Vaptans. Now, of course, in hypovolemic hyponatremia, we also use loop diuretics. And loop diuretics cause more water loss than sodium loss. Okay, so that will also help correction of the hyponatremia. So, Vaptans and the correction of hyponatremia. Systematic review published in 2010, 15 trials, randomized controlled trials, 1,619 participants. There was a modest increase in the serum sodium in 3 to 5 days of about 5. Okay? No report of osmotic demyelinating syndrome, and increase in sodium was 2.5 times higher than placebo. And in the other systematic reviews, you find the same thing. The main point is that the Vaptans do increase the sodium. The problem is they increase it sometimes very fast, and you can't control how much they will increase. Okay? So if they increase the sodium too fast, you have to spring into action. Otherwise, something bad may happen. So here is a real life situation where 61 patients with a mean sodium of 120, okay? And they were given either 7.5 or 15 milligrams per day of tall Vaptan, and they were told to drink. You have to tell them to drink because then the sodium will rise too fast. Right? Drink ad libitum, okay? No one developed ODS, but the mean increase was 9, but the problem is here. You had about a third of the patients whose increase was 12, more than 12. And these are the patients who may develop osmotic demyelinating syndrome because you don't have any control. So, how much do you want to increase? You do not want to increase the US guidelines say minimum is 4 to 8. Okay? The European guidelines do not give a minimum. And the limits are 10 to 12. Okay? And the limit is 10. So my feeling is some people use 6 to 8, some will use 8 to 10, but you don't want to go above 10. Okay? And why do you not want to go above 10? Because of the risk of the demyelinating syndrome. Here, 54 cases of ODS have been published in 1997. 96% was the diagnosis was based on MRI. In 96%, the starting serum sodium was less than 120. So, many people believe if your starting serum sodium is 125 or 128, the chance of ODS is very low. But if starting sodium is 120 or less, there's a chance of developing ODS. And in 85%, it was less than 150. Okay? And notice, in 87%, the serum sodium increased more than 12 during the first 24 hours and more than 20 during the first 48 hours. And that's where these guidelines are coming from. That's why they're saying, do not go more than 10. Okay? Because in the majority of these cases, the serum sodium went up by more than 12 in the first 24 hours. Okay? And what is this osmotic demyelinating syndrome? Okay? The it has a latent period. So after all this has happened, say accidentally the sodium went up by, say, 20 points. Okay? So for a couple of days, nothing happens. The patient is still the same. And then problems start. Dysarthria, dysphagia, paraparesis, quadriparesis, behavior problems, movement disorders, seizures, and then finally coma. And often irreversible or partially reversible. Okay? So that's what we are afraid when we overcorrect or correct too rapidly. So, once we start correcting, we've started giving our boluses or start giving the infusion, we should check the serum sodium Q2, Q4. Okay? The problem here is there's also variation in the lab. Some studies are saying up to 4 plus minus can be a lab variation. That creates even more confusion. Your lab, if your lab is not precise, you may have confusion. So, you want to watch it and not increase by more than, aim for like 6 to 8, maximum 10. Okay. So baseline, more than 1 probably unnecessary. Baseline 120, you start giving electrolyte-free water or desmopressin after correction exceeds 6 to 8. So you're going to start D5W, and you may give, say, 2 micrograms of DDAVP to bring the sodium down or make it not go higher, right? So I actually broke down for you this comparison of the US and European guidelines, okay? I just went piece by piece. And now let's go back to our case, okay? So I told you this 44-year-old man was admitted to Willis-Knighton Hospital, and he had a history of alcohol abuse. That's the kind of patient who can develop ODS, remember, And he had, He had seizures, subarachnoid hemorrhage, subdural, and on the 24th, we know his serum sodium was 140. But on the 1st, when he developed respiratory arrest and was admitted to a hospital, his sodium was 115. So he was actually, and notice his serum osmolarity was 249. Urine osmolarity was 457. It was not more than 500. Urine sodium was 32. It was not above 50. And they gave him plasma light. They said they thought that he was probably volume depleted. Okay? And the plasma light sodium went up from 115 to 130. So to me that is scary, right? Because it's gone by 15 points. Okay? So, but fortunately, nothing happened. But the next day, from the second to the third, he's gone down again. The sodium dropped. Okay? And they gave him 3% hypotonic saline at 60 cc's an hour. And he started getting better. Okay? So they remove his endotracheal tube. On the 4th, his sodium is 131. Okay? So what's happening is when they stop the 3% saline, sodium drops. So now they consulted nephrology, okay, to help them manage this case. And Dr. Buffington was on the case, so if I have written anything wrong, Mary, you correct me. So now on the 7th, mentition is improving, he's oriented, but still confused about location and year, can hold a conversation now. These are from the notes in the chart, okay? They stop the hypotonic saline, they restrict fluids, I'm assuming to 1,000 a day. They give him sodium chloride tablets. They are reading the recommendations, right? They're giving urea powder, which tastes horrible, but there's a formula where you can make it sweet and palatable. And I think they were giving him Lasix, okay? And the sodium now was 123, not oriented to place and time. Patient unable to restrict water. This was the patient's problem. He could not stop drinking. You know, he was not completely aware, so he could not restrict water. And so the sodium again started drifting. So finally a decision was made to start tolvaptan. We stopped the Lasix, stopped the urea, and he was started on 15 milligrams once a day, where he could drink as much as he wanted. And so on the 11th, the sodium is 133. They dropped the dose to 7.5, and on the 13th, it's 140. And he was discharged on tolvaptan, 7.5 with this sodium. When he came to the clinic, his sodium was 146, so he's now actually getting hyponatremic. And they changed the tolvaptan to every other day. So this is a case of severe hyponatremia from the brain because of the bleeding and subdurals. And probably with time, I think this patient, as he gets better, he probably won't need tolvaptan for the rest of his life because we know he had a specific cause. Okay. So I will end here. I think I have a few minutes if you are thoroughly confused. Mary, did you have any thoughts on that patient?
Well, you know, he was in the ICU, he was in the MICU most of the time, and they were actively managing all of his comorbidities.
So this is a dilemma. This is the kind of patient we have. And you worry, you know, if I raise it too fast, ODS, if I don't do anything, the hyponatremia may kill him. So I have to do something, I have to act.
Would you comment on using 3% saline as peripheral infusion or central infusion? Because I've had this discussion with pharmacy occasionally. You have to have a central line for 3% saline.
I did not explore that. So is there a danger of giving 3% through a peripheral line?
No, I think if you give it at a certain rate, it can be given.
But does it harm? Does it?
I think it's the osmolality. The osmoles are about 500 osmoles per liter.
Right.
So if you give it at a very fast bolus, it can potentially damage the whale. But if you give it over 15 minutes, 100 cc, it should not have it.
So are we allowed to give it in?
I'd send some information to the pharmacy. So I'm not very sure what the PNP board decided on this. Does anybody else use the peripheral ID?
We use it all the time. I mean,
Neurosurgery does all the time.
Right, but for some reason, the pharmacy and the floor refuse to give it, saying that
Do they do it on the floor or do
They'll give an infusion of 50 cc's an hour or so.
But they use boluses too sometimes, mostly in the neuro ICU.
On the floor, I.
that's where the discussion was, and I sent something to the pharmacy,
To the
and
ICU,
they
said,
should be okay.
the pharmacy said you can't do it on the floor. This was.
so you've ended up placing them in the ICU?
This should not be any reason to do
No,
that.
the problem is even on the floor, sometimes getting labs, you're going to do frequent labs. So I think if someone has profound hyponatremia, maybe.
Sure, but there are some stable patients where you know what the issue is. If you need more
Right.
acute care, you have to.
Right. So the distinction, if your patient doesn't have symptoms and most of the trouble is below 120, so if the sodium is above 120 and the patient is asymptomatic, I think you can just manage without 3%.
Very rarely you have patients who have a very high loss of sodium from studying of one patient I had severe oozing from the chest tubes. It was basically losing hypotonic fluid from the chest tubes, and no matter what you give him, the sodium will drop. So in that patient, we had to put him on 3% continuous infusion.
That's a special
Those
case.
are the main thing. Those patients, you just have to wish for the chest tube output to go down.
So that's like a hypovolemic hyponatremia. The salt losses are more than the water losses. Thank you.